Good evening, everyone. Welcome to the webinar series from the Department of Emergency Medicine, Yashoda Hospitals. Every week, we bring forth interesting topics that are relevant to the field of emergency medicine. For this week, the topic is hemodynamic monitoring. For this week, we have got a speaker from Narayana Institute of Cardiac Sciences. His name is Dr. Muralidhar K. He is currently the academic director at Anaesthesia, and he's working as a senior consultant and professor in the field of anesthesia and intensive care. He is a professor of international health at University of Minnesota, USA, and dean of Indian College of Anesthesiologists. Currently working as professor and senior consultant in the field of anesthesia. So he has also worked at NIMS as assistant professor in anesthesia, and he has done his fellowship in cardiothoracic anesthesia from Penfield General Hospital, Leicester, UK. Welcome, doctor. Good evening, and you can start sharing the screen. Thanks for joining us.
Good afternoon. I'm Dr. Muralidhar speaking to you from Bangalore. I'm just trying to share the screen. It says new share. Should I share it again? I don't know.
We can see the screen, but make it full screen, please.
Yeah. 1 minute. This option is not seen here. Slide control. Shall I see slide control? 1 minute. Can you see the screen now?
Yes, sir.
Is it visible?
But it's showing the presenter screen.
I see.
You'll have to change. Yes. Under the slideshow, just in, we can see.
Okay? Thank you for this invitation. I value this very much, and thank you for joining us. And I'll be dealing with the subject of hemodynamic monitoring in the next 25 to 30 minutes. As you know, the hemodynamic monitoring is the cornerstone of optimization of tissue perfusion. And this is necessary to prevent metabolic deterioration. So whenever the tissue perfusion suffers, there is metabolic acidosis leading to further deterioration of the patient's general condition in the critically ill patients, whether they are presenting to the emergency department or the intensive care department or in the operating rooms. These hemodynamic alterations and perturbations leading to instability may be caused by cardiac dysfunction or changing loading conditions such as decreased preload or increased afterload, or patients' other related factors such as pericardial disease, pulmonary embolism, etc. Monitoring of hemodynamics is absolutely essential to optimize pump function and maintain adequacy of circulation, both macro and micro circulation, improve tissue perfusion, and provide optimal outcome of patients. If you look at the heart, it's an amazing pump. It keeps on pumping 70 ml of blood every beat, 72 times a minute on an average. And if you notice that both systole and diastole are active process, which means that even in diastole, the heart is working and it is continuously pumping blood to the tissues in order to maintain the tissue metabolic requirements. And it is thus important or interesting to know what happens if something goes wrong with the heart. Let us take a case of a 63-year-old male patient presenting with a history of fever and not getting better with routine antipyretic agents, and is admitted to the intensive care unit or the emergency unit with a heart rate of about 120 per minute, which is regular but a bit less in volume. Blood pressure is low, tachypnea of 34 breaths per minute, SpO2 on room wave is 87%, and is having altered sensorium and decreased output. When you look at these patients, we need to look into a quick review of the condition, which includes listening to the patient's medical history, targeted histories obtained in a very succinct manner so that the time is essential, and then feel the extremities, see if there is any coldness of the extremities, and if it is sweaty, and look at the color of the skin, look for mottling, and the management includes the checking of the blood pressure, heart rate, and lactate levels if it's available. And the secondary survey, as far as the ACLS guidelines goes, is given by the mnemonic sample. That is, you look at the signs and symptoms, note the allergies, what are the medications patient is getting, what is the past illness, history of oral intake, and events leading to the present illness. Coming to the hemodynamic monitoring proper, I'll be dealing with invasive hemodynamic monitoring. The first one, I'll talk about arterial pressure, then we'll go on to the central venous pressure, pulmonary artery pressure, and the cardiac output. Arterial cannulation will be needed for the continuous real-time blood pressure monitoring in patients who are critically ill, whether they are in ER or in the intensive care unit. It's also necessary when you're planning pharmacological or cardiovascular manipulations, and arterial line is necessary to get repeated blood samplings. And if there's failure of indirect arterial blood pressure measurement, for example, you have an obese patient, or there is structural deformity of the arms, in such cases, you might have to use a direct arterial blood pressure monitoring. We also derive supplementary diagnostic information from the arterial waveform. And one of the most important things which have come into vogue in the recent decade or so is the determination of volume responsiveness by determining the systolic pressure variation or the pulse pressure variation. If you look at the arterial waveform, it is a combination of fundamental waveform, and the ultimate waveform will look like the one shown in the box on the right bottom. That is the typical arterial waveform. That is a summation of the harmonic waves which are produced as a result of flow of blood in the circulation. We need to define what is mean arterial pressure, and we have to know what is a dichrotic notch in the arterial pressure tracing. Mean arterial pressure is the diastolic blood pressure plus 1/3 the pulse pressure. That is diastolic blood pressure plus 1/3 the pulse pressure. And most of the management in the critical care units and most of the places in the hospital is dependent upon this mean arterial pressure, usually mentioned as MAP. It should be kept around 65 and above in normotensive patients, and higher values in patients who are diabetic or hypertensive and in elderly individuals. That is the first point which we have to remember all through: mean arterial pressure of 65 and above millimeters of mercury. Then coming to dichrotic notch, that I exhibit in the diagram here. This is the arterial pressure waveform tracing in relation to the ECG. So this is the arterial pressure tracing, and the corresponding ECG is shown in the green at the top of this panel. So you have the blood pressure on the vertical axis in millimeters of mercury. This is the arterial pressure tracing. This part 1 is the systolic upstroke. This is systolic pre-peak and the diastolic decline. And the fourth, the one which is marked as 4, is the dicrotic notch. And then we have the diastolic runoff and actual diastolic pressure. So the topmost is the systolic pressure and the bottommost is the diastolic pressure, and the mean pressure is somewhere in between here, because usually the cardiac cycle of 0.8 seconds, 1/3 is systole and about 2/3 is diastole. That's why they say that the diastolic pressure plus 1/3 the pulse pressure will give the mean arterial pressure. And what is important in this diagram is to note that the electrical events precede the mechanical events. That is the electrical event that is in the form of conduction from the sinoatrial node to the bundle of his. Once it reaches the left ventricle, that is the bundle of his, it has to traverse down and stimulate the myocardium. Then the myocardium contractions occurs, and then it opens the aortic valve and the blood is propelled into the aorta. Then the blood from the aorta goes to the radial artery or the femoral artery where you put the arterial line. So that much time is needed for the pulse to traverse the arterial system. Hence, there is a delay of about 80 to 120 milliseconds from the electrical activation as compared to the mechanical activity, as you see in the radial artery or the femoral artery. When we talk about the pressure monitoring, we need to understand that there are 3 physical principles. These are the frequency response, that is the ratio of measured versus input amplitude. At a given frequency, it should be really, ideally 1. That is, whatever is the pressure in the system should be measured and recorded same. That is the relationship with the pressure and the measured pressure should be 1. And the second property is the natural frequency, is the frequency at which the system resonates and amplifies the signal. It is dependent upon the diameter of the tubing, length of the tubing, the compliance of the tubing, and the density of fluid contained in the tubing. The natural frequency for arterial blood pressure should be between 10 to 20 hertz. And the diameter should be as big as possible, length should be as short as possible. It should be, the tubing should be non-compliant. It should not be swelling with each of the heartbeats. It should be non-compliant, and the density should be low. It should not contain any blood in the system. It should be filled with heparinase saline. The third important principle is called as damping coefficient, which is rate of dissipation of energy of a pressure waveform, and it is normally required damping coefficient in arterial line system is 0.4 to 0.6. And this tracing shows the underdamped arterial pressure waveform where the systolic peak is increased and diastolic pressure is lowered, and the smaller waves are magnified. But the thing is, the mean arterial pressure will be same. For example, as is shown in this example, the actual pressure is 120/60 and the mean of 80, but the machine reads 160/55. But as you notice, the mean pressure is similar to the actual pressure. So this is the underdamped waveform, and this is the overdamped waveform where the systolic pressure is lower and diastolic pressure is higher. But again, here the mean arterial pressure is similar to the normal, the actual value. And usual cause of underdamped arterial waveform is presence of clot or air in the system. So you need to remove the clot or the air in the system and keep the arterial line flushed all through to be able to get the actual real-time measurement of the arterial blood pressure. The measurement of natural frequency and damping coefficient can be done bedside by using the flush test. That is, you release the tag, pull the tag and release it, When you do that, the pressure suddenly rises to about 300 millimeters. That is the pressure you have exerted onto the bag by using a pressure bag onto the saline. And then once you release it, the oscillations are produced in the arterial line system, which settle down and you get the arterial tracing just after that. And if you look at the distance between the oscillations, that depends upon the natural frequency. As I said, it should be between 10 to 20 hertz. And the damping coefficient is the ratio of the amplitude of the waveforms which are produced by the fast flush test, and it is graphically derived, and it should be between 0.4 to 0.6. And there is no measurement for this value because of the fact that it is a coefficient. It does not have any connotation in terms of measurements. As the pulse wave passes distally, the systolic pressure increases, the diastolic pressure decreases, but the mean pressure remains same. And if you notice that the pulse pressure is increased as compared to the aortic arch as you're traveling across the femoral artery, and the systolic peak is delayed, and the diastolic waveform becomes slurred, and you may not be able to discern the dicrotic notch as you go far away from the central circulation. In the elderly individuals, because of the non-compliant nature of the arterial system, the systolic pressure may be increased because of the fact of reflection of the waveform which is coming from the peripheral system as the pulse wave is traversing antegrade from the contraction of the heart and producing a stroke volume into the arterial system. We'll quickly go into the abnormal waveforms. Pulsus bisperans is seen in patients who have aortic regurgitation. Pulsus parvus and tardisi in aortic stenosis, where the rise of the pulse is slow and the peak is delayed. Pulsus paradoxus is seen in patients who have constrictive pericarditis or pericardial tamponade. Pulsus alternans is seen in patients who have left ventricular failure or severe respiratory failure, where every second beat is weaker beat. And reverse pulsus paradoxus is seen in patients who are on mechanical ventilation. The differentiation between pulsus paradoxus and reverse pulsus paradoxus is that in pulsus paradoxus, there is decrease in the systolic blood pressure with inspiration. There is decrease in the systolic blood pressure during inspiration. And if this decrease is greater than 10 millimeters of mercury, it qualifies to be called as pulsus paradoxus. Up to 6 to 10 millimeters of difference in the systolic pressure between the respiratory cycle, inspiration and expiration is normal. And this phenomenon is reversed if you start mechanical ventilation using a tidal volume of greater than 8 ml per kilo, and the patient is sedated and paralyzed. With the inspiratory stroke of the ventilator, the systolic blood pressure rises. Please note this difference. In spontaneous breathing, systolic pressure falls, whereas in mechanical ventilation, systolic pressure rises during inspiratory phase of breathing. So some of the waveforms are shown here. This is the normal waveform. On the left-hand side, we have the arterial pressure scale, whereas on the right-hand side, you have the pulmonary artery pressure scale. The dark red one is the arterial pressure. The light red one or the orange colored one is the pulmonary artery pressure. And this is the, as I already said, the relationship between the surface electrocardiography and the arterial pressure tracing is shown here. You should not think that with R wave there is a stroke of the arterial system occurs coinciding with it. It is not so. It is delayed because of the factors which I mentioned in the last few slides. And this is a patient with aortic stenosis. You see that the arterial pressure waveform is blunted and the peak is delayed. And this is a patient with aortic regurgitation showing pulsus bisferens. Because of the regurgitation, the pulse comes back into the left ventricle because the incompetent aortic valve producing a second waveform And in patients who have HOCM, there will be a spike and dome pattern as is shown here because of the LVOT obstruction. Now coming to pulses alternates, as I said, every second beat is a weak beat. This should be differentiated between pulses bigeminy and pulses alternates because in both conditions, every second beat is weak. In pulses bigeminy, the differentiating feature is that in pulses bigeminy, the ECG will show every second beat as an ectopic beat, whereas in pulses alternates, all the beats are regular and it is sinus rhythm usually. And this is reverse pulses alternates seen in mechanically ventilated patients with inspiration. There is increase in the pulse pressure, and this is a pulse pressure. Pressure waveform seen in patients who are on an intra-aortic balloon pump. 2 cardiac cycles are shown here. This is the starting point of the second cardiac cycle. This is unassisted diastolic pressure. This is unassisted systole. This is the dicrotic notch. This is diastolic augmentation. And then the diastolic pressure is lower than the previous diastolic pressure because of the reduction in the afterload, which is given by the intra-aortic balloon pump. This is systolic pressure variation. That is a patients who are on mechanical ventilation with a tidal volume of 8 ml to 10 ml per kg. With each inspiratory stroke, there is increase in the systolic pressure. This is an index of fluid status, and any value which is greater than 13% indicates that the patient is likely to be fluid responsive. And if the patient is hypotensive, we must administer the IV fluids or whatever is the colloids or blood, whichever is applicable or appropriate to that patient's condition, to be able to maintain this systolic pressure variation less than 13%. The other measure of fluid responsiveness is the pulse pressure variation, which is the pulse pressure maximum and divided by minus the pulse pressure minimum divided by the mean pulse pressure. This also should be less than 13%. If it is less than 13%, it means that the patient may not be fluid responsive. If patient continues to be hypotensive and the pulse pressure variation is less than 13%, it means that we need to use inotropes or vasoconstrictors to be able to maintain the blood pressure adequately appropriate to that patient's condition. Second parameter which is used in hemodynamic monitoring is the central venous pressure. This is the central venous pressure tracing. We have the A, C, and V waveforms which are positive, and we have the X and Y descents which are negative in connotation. The A wave is produced as a result of atrial contraction, that is a part of diastole, and systole actually starts from somewhere here. And as the systolic function starts to occur, the tricuspid valve bulges into the right atrium because of the isovolumetric contraction, where both the pulmonary valve and the tricuspid valve are closed. The heart is trying to contract now. So during this phase, there is gradual increase in the intraventricular pressure, and the tricuspid valve on the right side and the mitral valve on the left side bulge into the respective atria and produce a positive wave which causes the C wave. And then as the heart contracts, the atrioventricular valve is pulled towards the apex and there is a relative negative pressure, and this leads to the formation of X descent. And then you have the diastole with mitral valve opening here and decrease in the relative decrease in the right atrial pressure or the central venous pressure, leading to Y descent. Central venous catheter placement is needed when patients are in critically ill conditions to know the volume status. Though it is not considered as a monitor of volume status as it is not a dynamic parameter, but serial values may be useful to assess the fluid status. And also, if the central venous pressure is low, you can be certain that the patient is hypovolemic and you can take appropriate steps. It is also necessary, central venous catheter is necessary to use vasoconstrictor drugs, vasoactive or irritating drugs, and whenever you have inadequate peripheral IV access. To give volume resuscitation, central venous line is also useful. The interjugular vein has a straight course from in the neck, and hence it's easily accessible, and most common site of placement of central venous catheter is the internal jugular vein on the right side. It is a continuation of sigmoid sinus, and it has a straight course, and there are no valves in this major vein, and there is a straight course into the right atrium, and hence most often it is used as the site of monitoring for central venous pressure. And this is a ultrasound image of the internal jugular vein. This is the carotid artery. This carotid artery usually is pulsatile, and this vein is easily compressible. That's a differentiating point from a artery and a vein when you're doing the central venous cannulation using the ultrasound to access the central venous circulation. Central venous pressure is measured during end expiration. This is the inspiration and this is the expiration. So it must be mean pressure should be determined at the end expiratory phase, and central venous pressure is determined. This diagram shows the relationship between the central venous pressure tracing and the components of the ECG and the arterial tracing. See, this is the P wave. It corresponds to the A wave. So the A wave, you can be rest assured that A wave is produced by the contraction of the atria. And this is the start of the systolic phase of the ventricular contraction. Systole, this is the isovolemic contraction period producing C wave, and then actual systole from here to here, actual systole from here to here. So the mitral valve or the tricuspid valve respectively on the left and right sides is pulled down because of the contraction, and you have the mitral valve opening here, and then the pressure decreasing. This is the diastole, starting of the diastole, and this is the end diastole, which causes the atrial contraction. And various disease conditions are mentioned here. Patients who have atrioventricular dissociation, there will be a big A wave because atrium may be contracting against a closed tricuspid valve, because there is no synchrony between the atrial and ventricular contraction. Patients who have atrioventricular dissociation. And in patients who have tricuspid regurgitation, the C and EV waves may be combined together, as is shown here. There may be single CV wave because of there will be no isovolemic contraction phase in patients who have tricuspid regurgitation, because as soon as the right ventricle starts to contract, the tricuspid valve will open and blood is being pumped into the right atrium because of the incompetent tricuspid valve. Now coming to the next section of the hemodynamic monitoring is the pulmonary artery catheter. This pulmonary artery catheter is typically 110 centimeters long. It's made up of polyvinyl chloride, which is radio opaque, and this catheter is flexible, and it is, as I said, it is radio opaque. And typical catheter has 4 lumina. Here I think you can see 1, 2, 3, 4, 5, 6 lumina are there, but typical Swan-Ganz catheter has 4 lumina. One is for inflating the balloon, which is at the tip of the catheter, which acts as a float to the catheter. Then there is a lumen which opens into the right atrium. This lumen opens into the right atrium, and the other lumen opens into the distal part of this catheter, which is used to measure the pulmonary arteries pressure. And you have a thermistor which is placed, the tip of which is placed at about 4 centimeters from the tip of the catheter. These are the 4 main components of a Swan-Ganz catheter. And the catheter is passed using the pressure transduction. This is a diagrammatic representation of the catheter going from the internal jugular vein through the superior vena cava into the right atrium. Once you enter the right atrium, you can inflate the balloon. And before that, you will see the right atrial pressure waveform, which will be exactly the CVP waveform, which we described with A, C, V wave components. And this balloon, when inflated, will act as a float to the catheter. It also prevents the contact of the catheter with the wall of the right ventricle and prevents arrhythmias. And when in the position, for example, here, the inflation of this balloon is necessary to produce the pulmonary artery occlusion pressure, which is a reflection of the left atrial pressure. So once you are in the right atrium, you inflate the balloon and across the tricuspid valve enter the right ventricle. The right ventricular pressure tracing is shown here. The systolic pressure normally is about 25 to 30 millimeters and diastolic pressure is 0 to 5 millimeters in the right ventricle. And across the pulmonary artery, if you float the catheter into the PA, you get the PA tracing, where the systolic pressure remains 30 or 25 millimeters systolic, but the diastolic pressure rises to about 15 millimeters as compared to the right ventricle. So the right ventricular diastolic pressure is 0, whereas pulmonary artery diastolic pressure is about 15 millimeters of mercury. And as you further progress the catheter into the pulmonary artery, you can occlude the pulmonary artery branches and you get the pulmonary artery occlusion pressure, which is a reflection of the left atrial pressure. And the normal value of the left atrial pressure is about 6 to 12 millimeters of mercury. Please remember that normal left atrial pressure, same as left ventricular end-diastolic pressure, is about 6 to 12 millimeters of mercury. Left atrial pressure is 6 to 12 millimeters of mercury. What happens in severe mitral regurgitation? As what we saw in tricuspid regurgitation, the A and C and A V waves are merged because of the blood is entering into the left atrium because of the incompetent mitral valve during systolic contraction of the left ventricle. Blood is entering into the left atrium because of the incompetent mitral valve, and hence C and V waves will be merged. And the height of the V wave in mitral regurgitation, when you are monitoring the left atrial pressure using the pulmonary artery flotation catheter, you have inflated the balloon. So you are getting the left atrial pressure monitoring on the screen. The height of the V wave in such case will depend upon the volume of regurgitation. Greater the volume, higher is the V wave, and compliance of the ventricle, compliance of the atrium, poorer the compliance of the atrium, higher is the wave, and volume of the left atrial volume. If the left atrial volume is lower, then you will get a lower tracing. But if you have a left atrial volume which is more, you will get a higher tracing. This is in a patient's myocardial ischemia. There will be increase in the V wave tracing of the left atrial pressure. That's the pulmonary artery occlusion pressure tracing. This is because of the fact that if there is myocardial ischemia, there is papillary muscle dysfunction leading to mitral regurgitation and producing a large V wave in the tracing. The pulmonary artery catheter typically should be placed in the zone 3 of the lungs. As you know, this lung is divided into 3 zones as propounded by West. This is called West zones. Zone 1, Zone 2, and Zone 3. Zone 1, Zone 2, and Zone 3. In Zone 1, the pulmonary alveolar pressure is greater than the pulmonary artery pressure, which is again greater than the pulmonary venous pressure. Pulmonary alveolar pressure is greater than pulmonary artery and pulmonary venous pressure. In Zone 2, pulmonary artery pressure is greater than the pulmonary alveolar pressure and pulmonary venous pressure. And in Zone 3, the pulmonary artery pressure is greater than pulmonary venous pressure and the pulmonary alveolar pressure. When you want to measure the left atrial pressure, the catheter should be in the zone 3. Normally, when you float the catheter, it usually passes into the lower lobes, lower branches of the pulmonary artery, and automatically it goes to zone 3. But you must check the X-ray to see that it's not gone to the upper zones of the lung, where if you're mechanically ventilating with PEEP, whatever is alveolar pressure will be reflected as an LA pressure erroneously. This is the relationship between the left-sided and right-sided pressures. And what are the factors which influence the relationship between the volume and pressure at various levels? If you take the left ventricular end diastolic volume, that is the left ventricular end diastolic volume, it is reflected by the left atrial pressure, measurement of left atrial pressure in the presence of normal mitral valve. If the mitral stenosis is there, left atrial pressure will be higher than the LV EDP. So in the presence of normal mitral valve, LV EDP will be equal to left atrial pressure. Similarly, left atrial pressure will be equivalent to the pulmonary artery occlusion pressure in the presence, in the absence of pulmonary venous occlusive disease or high degrees of PEEP. If you are applying more than 5 centimeters of water of PEEP, suppose you are giving 10 or 15 centimeters of water, this relationship will not hold good. In patients who have pulmonary hypertension, the relationship between the pulmonary artery occlusion pressure and pulmonary artery diastolic pressure will not hold good. But if the pulmonary vascular resistance is normal, pulmonary artery occlusion pressure will be same as pulmonary artery diastolic pressure. And coming to the right atrial pressure, that is the CVP, is same as the pulmonary artery diastolic pressure in the absence of tricuspid disease or diastolic RV dysfunction. This diagram shows the relationship with the transmural pulmonary artery wedge pressures. And in spite of the fact that the LV volume is same in all 3 conditions, this is patient with pericardial effusion, the pericardial pressure is increased. But the volume contained may be same but the transmural pressure will be low. Transmural pressure in this condition will be low, whereas in these cases there is a stiff left ventricular pressure, stiff ventricle, the transmural pressure may be higher. Now coming to the next modality of monitoring is the esophageal Doppler. This is probe Doppler echocardiography. It's not echocardiography, ultrasonic probe passed into the esophagus. It stays behind the heart and it measures the flow in the aorta. And the flow in the aorta is computed to give the cardiac output, taking the factor of the blood flow which is going to the circulation. This machine usually is calibrated that the aortic blood flow plus 1/3 the aortic blood flow with the total cardiac total flow, which can be related to the cardiac output. So this is the monitor which gives us the continuous cardiac output measurement using the pulmonary artery catheter. Now coming to the cardiac output, it is a stroke volume into the heart rate. Stroke volume is in turn dependent upon the preload and afterload and the heart rate. The cardiac output in preference to the body surface area, it is called the cardiac index. Normal cardiac index is between 2.8 to 4.2 liters per minute per square meter body surface area. The cardiac index is between 2.8 to 4.2 liters per minute per square meter body surface area. Cardiac index is preferable rather than cardiac output because of the varied body sizes. For example, you can have an adult patient with a body weight of 40 and another adult patient of 90 kgs. So if you go by cardiac output, what is normal for 40 may be low for a patient who is 90 kilos. So hence you have to go determine the cardiac index to be able to have the uniform values as normal values for a given particular patient. This already I said the stroke volume depends upon the preload, afterload, and contractility. And the cardiac index is determined by dividing the cardiac output by body surface area. Normal values are 2.8 to 4.2 liters per minute per meter square. There's various techniques to measure, but usually we use the thermodilution technique and use the echocardiography based techniques. And sometimes we use the pulse contour analysis, especially in intensive care units where you do not want to have a pulmonary artery catheter. We use the pulse contour techniques. I'll be quickly dealing with them in the next 5 to 10 minutes. Fixed method depends upon the determination of the oxygen consumption and the oxygen content of the arterial blood and the mixed venous oxygen content. So this is cumbersome to do, so it's not usually used. And the usual technique of measurement is the thermodilution technique, where cold saline is injected into the right atrium. And as it passes through the right ventricle into the pulmonary artery, this saline cools the blood at the tip of the catheter. And this is sensed by the thermistor, and you get the cooling curve. And this cooling curve gives us the cardiac output by using this Hamilton-Heward equation. And the other method to do is continuous cardiac output, where there's a thermal filament, which is heated to 42 degrees in a pseudo-random fashion. And the amount of heat generated here is measured at this point by the use of a thermistor. And then here you're heating the blood to about 42 degrees. Pulses of heat waves are generated and given to the blood here. And the change in the temperature is sensed here by looking at the temperature change. For example, as is shown here, this is the blood going from the right atrium, right ventricle across the pulmonary artery. This is the thermal filament, which is heated in a pseudo-random fashion for brief periods of time. This is the heat being generated. It is imparted to the blood, which is going into the circulation, into the right ventricle, through the pulmonary artery. And the temperature is sensed at the tip of the catheter. And by knowing the amount of temperature change, we can get the amount of blood flow which is occurring, that is the cardiac output. Coming to the pulse counter analysis, you can have arterial waveform when you have cannulated the artery. You can have either external calibration or internal calibration. We have various techniques. I think flow track is commonly employed, but other techniques are also available. And this is a picture of the videoscopic picture of the sublingual microcirculation. This is the normal distribution of circulation. And in patients who have sepsis, you can see that because of serious vasoconstriction, some of the blood vessels are closed. And this is an important reason for tissue hypoxemia, which occurs in these patients. Other measurements are vasoreactivity tests and carbon dioxide gradients in the arterial and venous systems, and venous oxygen saturation, especially the mixed venous oxygen saturation and semi-venous oxygen saturation, can be used to indirectly determine the status of the cardiovascular system. And in patients who have hemodynamic instability, several algorithms have been proposed to determine the treatment pathways, diagnosis and treatment pathways of these patients. And this slide shows the oxygen consumption and oxygen delivery. On the vertical axis, we have the oxygen consumption. Oxygen delivery is on the horizontal axis. This is as the oxygen delivery delivery decreases. This is the oxygen delivery as it decreases and reaches a critical point. The shock state ensues, which is associated with increased lactates and decreasing mixed venous oxygen saturation and central venous oxygen saturation. So we need to catch the patients before this occurs by maintaining the oxygenation, the blood, cardiac output and oxygenation. This is a curve showing the relationship between the mortality and morbidity and the central venous oxygen saturation. It should be in this range, which is about 65 to 80%. Now, high is also not as good, and low is also not good. If it is high, it might mean that there are arteriovenous connections or shunting of blood at the peripheries. That's why tissues are not able to take up the oxygen. In conclusion, what I have done is I have given you a bird's eye view of mostly the invasive cardiovascular monitoring, which is most important in patients who have unstable cardiovascular system, that is critically ill patients. This is essential to prevent metabolic deterioration and maintenance of the cardiovascular system and tissue oxygen supply and microcirculation. Thank you so much for your patience, and if there are any questions, I'll be happy to take them.
The questions can be posted in the Q&A section, or you can use the chat section.
I hope whatever I spoke was clear.
Yes, sir. It was, though you said bird's eye view, it felt very much elaborate, and you have covered the entire graphs and all. So they look simple, but understanding is not that easy. Thank you so much for covering.
Right. Lot of research is happening in this area now. The concentration of the microcirculation, how to monitor the microcirculation. We always concentrate on the macro circulation, that the blood pressure and heart rate and etc. We also have to look at the downstream parameters like lactates, base excess, and venous oxygen saturations.
Someone posted a question. What is zeroing?
Zeroing of the transducer is very important. There are two things which we should look at. One is the leveling of the transducer. The transducer is usually leveled to the fourth intercostal space in the mid-axillary line. That is considered to be phlebistostatic axis because it to some extent represents the left atrium, and so it is reference to that point, whatever pressure we are measuring. That is leveling. These terms should not be confused. Leveling and zeroing are different. Leveling is done where the transducer is kept at the same level as the phlebistostatic axis. That is one. Zeroing is the exposing the transducer to the atmospheric pressure. In all monitoring systems, especially pressure monitoring systems, the atmospheric pressure is considered to be zero, and any pressure above atmospheric pressure will be taken as the actual pressure in that particular vascular system. Hence, the transducer is zero when the transducer is exposed to the atmosphere by turning three-way tap to the atmosphere. Then you press the zero button on the monitor. Once it is zero, you again turn the three-way tap to the vascular system and get the actual pressure in the vascular system. Please note that these pressures are above atmospheric pressure, but we take atmospheric pressure as zero. Slide on SpO2 to mixed venous. SpO2 to mixed venous oxygen ratio. Are you talking about the critical? Yes.
You can click from current slide, sir. Yes.
Are you referring to this slide? I don't know his name. We have the oxygen consumption here and oxygen delivery here. Usually, oxygen delivery exceeds the consumption. Actually, if you give 1000 ml to the body, it takes 250 ml and remaining 750 ml comes back to the circulation. Usually, that is the oxygen extraction ratio. We express it as 25%. If you give 100, 25 is taken and 75 comes back to the heart. That's why you get a mixed venous oxygen saturation of 75%. So, but in patients who are critically ill, the oxygen extraction may be more. And there is a critical point beyond which, as the oxygen extraction is continuing and delivery is falling, as the critical point is reached beyond that, metabolic acidosis sets in because the oxygen supply is not in tune with the requirements, and there will be anaerobic metabolism and lactates are produced. That's why you get lactic acidosis, and you measure lactates as a part of treatment strategy in patients who are in shock states, whether it is cardiogenic or septic or obstructive or hemorrhagic shock, whatever the shock may be. As soon as the delivery of oxygen falls below the critical point, the tissue acidosis increases, starts to manifest, and this is also indirectly reflected in the fall in the mixed venous oxygen saturation and central venous oxygen saturation. I don't know if this is what you wanted to know.
I think that was it. To better understand this, read the slide from right to left.
Right, that's true. So this is the delivery as it is coming down, which is marked in black here. The SCVO2, that is also a reflection of the mixed oxygen extraction, how much oxygen is coming back to the right side of the heart. So this drastically falls beyond the critical point, and lactates in the red line, sharp rise in the lactates. And this is the shock area where the delivery of oxygen is not able to match the requirements.
I think that was it, sir. We don't have any more questions.
Somebody wants 55 slide. I don't know which one is that.
Yeah, that was the same, sir.
Same.
Yes. Dr. Srinath wanted to speak actually. So.
Thank you very much, sir. Thank you very
so
much for your kind time. It was very, very useful for all the residents. And as usual, whenever we hear to your lecture, it's very rejuvenating, and the knowledge what you have shared today will be helpful for the day-to-day practice. Thank you very much, sir.
Thank you for the opportunity, and thank you for kind comments. Thank you so much.
We'll be closing the session, sir. Thank you so much.
Thank you so much.